Hello, this is Morton Kern. I'm one of the clinical editors for the JSCAI section on hemodynamic pearls, and it's a pleasure to be here today with Dr. Larry Dean, Dr. Arnold Seto, Dr. Gurumurthy Hiremath, and Dr. Jonathan Fang, our guest presenter on a hemodynamic pearl case. And I am delighted to host and moderate this session on hemodynamics. Dr. Fang and his colleagues gave us this case of subaortic membrane and cardiac catheterization. Beware of the diagnostic pitfall. And our panel today, Dr. Fang, as I just mentioned, is a Center for Structural Heart Disease at Henry Ford. Dr. Fang, are you a fellow or are you faculty?
I was a fellow, actually. I just completed my fellowship in June.
Congratulations.
With the structural heart team there.
Okay, and so Dr. Dean, Larry Dean is a JSCAI section editor, professor emeritus of medicine, and founding director of UW Medicine Heart Institute in Seattle, Washington, and always a heavy hitter in hemodynamics. Gurumurthy Hiremath, also a JSCAI section editor, associate professor and associate division director of pediatric cardiology and director of the congenital cardiac cath lab at the Heart Center in Minneapolis, Minnesota, and my colleague and partner at the VA in Long Beach, director of the cath lab, Dr. Arnold Seto, who also has high interest in all things hemodynamic and physiologic. So let's just start right in. Dr. Fang, why don't you go ahead and present your case?
Okay, so I've made this as simple as possible. So the case was a 39-year-old lady. She had a long-standing history of dyspnea that has previously been attributed to related to a body mass index of 45. Her past history includes hypertension. She is currently in New York Heart Association Class 3. She was referred to us after being found to have an ejection systolic murmur at the right upper sternal border. An outside echocardiogram showed mainly poor imaging quality, or perhaps relating to the body habitus. So we have repeated the first transthoracic and then a transesophageal echocardiogram and reviewed a gradient of 82/43 around left ventricular outflow tract. And on physical examination, there was the murmur reproduced, but any maneuvers on dynamic auscultation essentially did not change the murmur. We can see on the on view that the aortic valve was opening well. There was also no significant features of abnormal asymmetrical left ventricular hypertrophy that would point towards the diagnosis of hypertrophic cardiomyopathy. So we took this patient to the cath lab. So we did we crossed the aortic valve. We did a ventriculogram. There was a faint radiolucency somewhere underneath the aortic valve. We used a dual lumen pigtail catheter to attempt to obtain a pressure gradient, but we found nothing. This was similar to a previous catheterization result. So we can see here the aortic tracing and the left ventricular tracing, and there was no gradient. And then we did a pullback on a standard speed, and we see that even on pullback, we didn't find any gradient at all. So we was convinced that there was something there, but we couldn't find a pressure gradient. So there has been previous reports of an entity called the subaortic membrane, which could be missed on catheterization. But in the literature, there hasn't really been an illustration or proof of an explanation of why that is the case. One of the suspected reasons is the catheter could open up the membrane when it is across, because the membrane is pliable. It's not a fixed structure. So next slide, please. So we did a catheterization together with real-time transesophageal echocardiogram, and we was able to visualize a discrete structure underneath the aortic valve, which was a subaortic membrane. That we can see it with a slight flapping movement, and it closes and causes obstruction in the left ventricular outflow tract. And intriguingly, we can see that when the catheter passes through it, it opens the membrane. And we think this is the reason we didn't detect any pressure gradient with the more common method of using a dual lumen catheter, or rather a more convenient method. So we replaced the dual lumen catheter with a single traditional pigtail and try to do a very slow pullback. And we can see that when we try to position the catheter just between the membrane and the aortic valve, the membrane was able to come back to its original position. Now, this did not happen immediately. It actually took a while for it to return to the position. This explains why with a dual lumen catheter, even on a pullback, we couldn't find a gradient. But here we can say that we can see that when the catheter moves across from underneath the membrane to between the aortic valve and the membrane, that there's a pressure drop that was significant, 40 millimeters of mercury, which agrees with that from the echocardiogram. And then when the catheter was placed at this position and slowly further pulled back across the aortic valve, we don't see we see an aortic tracing, but no pressure recovery, meaning that this gradient is a real gradient. It's not due to the Bernoulli effect. So that's, and with this, together with the intraprocedural transesophageal echocardiogram, we confirmed the diagnosis of a aortic membrane, and the patient was referred for surgery.
This is a great case, fascinating. I need to spend a couple minutes and discuss with the group and you, of course, the tracings that we're looking at. So let me refresh our memory. If you have a valvular aortic stenosis, your tracing should look like this. So this is from a dual lumen pigtail. You have the classic severe aortic stenosis, delayed upstroke in the aortic pressure, that's the red line, and big gradient, late peak, loss of A2, S2, and a true aortic valve problem. Now, sometimes, here's another tracing we took from a patient who had an aortic valve in place. There was this initial rapid impulse upstroke and then a late gradient, which is kind of atypical for classic AS, but it shows that there can be some variance in the shape of the aortic waveform. This was thought to be related to the valve ring and not the valve itself. And then I did want to ask you some detail about this graphic because it's fascinating that on the left, this is a typical normal aortic LV pressure relationship. On the right, you have your gradient identified with your pigtail between the two. And I presume if you would have had an aortic pressure, it would be down here in the lower, at the gradient level. And, this aortic pressure certainly doesn't look like it's being impacted by any kind of gradient generator. That is, you have a gradient, should you not see some disturbance in the aortic pressure as well? Now, my colleagues can comment, but I'd be curious. And lastly, the shape of this intracavitary, I guess not intracavitary, the space between the valve and the membrane has this peculiar left ventricular pressure tracing. So if this is above the membrane, and this is below the membrane, no, below the valve, but above the membrane, it should be aortic. Should it not? And the gradient should be across the membrane.
Yeah. Yeah, okay. It somehow resembles the ventricular tracing, but it's not an aortic tracing. It's the lower, this was the area between the aortic valve and the membrane.
It sure looks like it looks like an LV tracing to me. And yes, that's why I was puzzled. I'm still puzzled. I don't know. Larry, do you want to comment on this? Arnold or Guru? Anybody?
Yeah, I share your question. I think that we'll get to this at sort of the very end as well. Sometimes these catheters, depending on where the side holes are located, I think this thing may have been splayed out during part of this because of the catheter. It was mentioned a moment ago in the presentation. But it may also be due to the fact that it's a little hard sometimes to really pick out, because you're talking about, sometimes several millimeters between the aortic valve and the membrane. So it's sometimes very difficult to kind of pick that out and see the change as you pull back on the catheter. So,
yeah. So I think you're right. Now, this tracing would come from distal in the LV, and this tracing to the right of it would come from the point between the membrane and the aortic valve. Correct? So this is on your pullback from deeper to shallower, just like the Holcomb patient, because your gradient is produced under the valve, under the valve, of course, under the obstruction. So this should be under the obstruction. So Dr. Fang, is that what I'm looking at here? The pullback from deeper in the ventricle to just between the two, to the membrane and the valve itself?
Yes, it was a very slow process. It's kind of more like a catheter positioning than the pullback, but we did see a change in this. I assume the membrane was allowed to resume its original position, but it doesn't act like a valve where it completely shuts the outflow tract. That's why I believe it's looked distinctly different from that of an aortic tracing.
So let me ask Guru and Arnold, does a membrane, can you push the membrane out of the way to create this tracing on the left so that this is an artifact, but with the same catheter, you should have the same effect, but you use TE to position it a little different. So usually stiff valves can be pushed open on occasion, but this was a very soft membrane. Any comments on the type of membrane that produces obstructions?
I think this case is fascinating for many reasons. And the point that you bring up, that the membrane is so soft it can be moved away from catheter, is certainly very unique. As a congenital interventional cardiologist, we see a lot of membranes, patients with subaortic membranes, and they are almost always fibromuscular in nature. And when the surgeon goes to carve them, it is not always easy
right.
to cut it out. The fact that this was so soft and able to be displaced with the catheter is, I would say, certainly unusual, and I haven't seen that in my experience. What do you think, Dr. Seto?
Yeah, I have not seen that before. I mean, I've had cases where someone suspected in an obese patient severe AS, and I crossed the valve easily and had no gradient. So I said, nope, they're just wrong. And most often that's just from the mitral regurgitation being incorrectly identified as an aortic stenosis gradient. But now I have to think, maybe there was a subaortic membrane there. The catheter just transiently pushed it away. In which case, then, are we really going to be, MRIing or TEing every aortic stenosis? I think, clearly in this case, you had a echocardiogram whose leaflets of the aortic valve were not consistent with the severe AS suspected, and so that led them to look further. I've had one case of this where I sent it to the surgeons, and they were quite disappointed that, we suspected severe AS, and they were not prepared to do a resection, and they asked me, is there any way you could have known beforehand from the waveform or anything? And I thought, is there any difference in that waveform? And I really couldn't say that there was. But I thought I'd share some of these views from the surgical literature of what anatomically the subaortic membrane looks like. On the lower right, you see before resection, you see these thin aortic valve leaflets, you see the subaortic membrane, and then after resection, it's all been excised. And similarly on the upper right, you can see the normal looking aortic valve leaflets, but when they're splayed open, you see the subaortic membrane, which is quite tight. And then finally, just 4 years ago, the ESC guidelines for congenital heart disease have basically confirmed that surgery is indicated when the mean gradient is above 40, as in this case.
You know, Arnold, you mentioned the waveform of the LV or clues that this may be something different. I think that LV waveform that was finally got with the single lumen is peculiar for an AS patient. So it's clearly not AS. It's more hokum-like in some ways, but I don't think it's dynamic. And now, just one more word: the teachings for valves is that catheters cross valves and don't prop them open. That is, we measure gradients across pulmonary, tricuspid, everybody, and generally catheters don't create falsely negative gradients. The leaflets coapt around the catheters, we measure the gradients, and we do fine. The only ones that can do that are the really super rigid ones that are almost calcified that you sometimes can prop open. But maybe that's a little bit more of an exaggerated perception. But I think this is very unique in that you were able to reposition it and find your gradient. So, Hiru, you sent us these fascinating images in an 8-year-old. You want to tell us about these?
Yes, I just wanted to highlight how we approach in pediatrics multi-level gradients in the LVOT, or for that matter in the RVOT. Here's an example of an 8-year-old child with a past history of interrupted aortic arch repair and has a complex fibromuscular subvalvular aortic stenosis, as you can see in the angiogram, LV angiogram on our left. And then what we generally do is, instead of using a multi-hole pigtail catheter, we prefer to use an end-hole catheter with a coronary wire. And as we carefully pull back, we measure pressures with the end-hole catheter and sometimes with the pressure wire. And we stop along the LVOT. And if we come above the aortic valve, then we advance the catheter again down to find that real sweet spot. And sometimes we take small angiograms during the time, as shown in the second angiogram to the right, to make sure we are below the valve. And then, as seen in the Mullins diagram here, the pressure in the LV is 153, just below the valve, but above the subvalvular obstruction, it's 95. So there is a gradient of approximately 60. And then there is often pressure recovery up to the ascending aorta. In this patient, there is also aortic arch obstruction, which is not relevant to this discussion. But I do find using a pressure pullback and using end-hole catheter and a coronary wire would help delineate the level of obstruction.
So that, I think this is really excellent. And the use of the pressure wire and guide multi-purpose catheter, that's one of my preferred methods. Although the most easy standard method for any kind of aortic stenosis in which you have that question is the dual lumen, but the pressure wire with the guide catheter offers you some really, I think, precise information. That is, you'll be able to pull that back, have your LV pressure, have your aortic pressure when you get to it, and know exactly where you get that. Larry or Arnold, you have preferred methods for gradient detection? I like Guru's method here with the pressure wire.
Yeah, I'll cover this in, I think, the next slide or so.
Okay.
But I think that what I was about to say, though, is I think that using that guide wire or pressure wire really allows very precise location of the abnormality. Even if you're dealing with somebody with hypertrophic cardiomyopathy, we don't do that much anymore because echo usually tells us what's going on. But nonetheless, pulling back very slowly with a catheter that has a single end hole in it and no side holes or one or two side holes that are very focal gives you a lot better ability to pick up something like this. Is very focal. Again, it would have been very interesting to see how it would have turned out with this particular subaortic membrane being very flexible. I'm not sure what would have happened, but it would have been interesting to look at that.
Yes. Larry, I'm going to come back to you for your final pearls in just 1 second. I have Arnold to give us just a word on, Arnold, what happens to these patients when they undergo resection? So let me ask, Guru, not Guru, but Jay, Dr. Fang, did your patient undergo resection?
Yes.
And I remember you reported he did pretty well.
Yeah, the patient did well afterwards.
Okay, so he would be in this kind of data set. So Arnold, did you want to describe what you're showing us here?
Yeah, just wanted to highlight some of the surgical literature. Originally, there was some thought that these patients have a high risk of recurrence of subaortic membrane, and it's really disturbing, of course, to undergo cardiac surgery twice. So some surgeons initially advocated for a myomectomy at the time of resection of the membrane, and but more recent case series, such as this one, suggested that a myomectomy is not necessary and didn't seem to reduce the risk of reoperation, and in fact increase complete heart block. Risk factors for reoperation included being a woman and any progression of the gradient seen, but they couldn't seem to reduce it just with a myomectomy. So I thought I'd toss that in just as a surgical pearl.
Well, it's good to hear. And I think the diagnosis here was really saved the day for this patient. So Larry, I'm going to let you wrap up with your hemodynamic pearls general thoughts.
Sure. Thanks. So I think, again, the first bullet point here, we talked about this already, but if a non-invasive assessment shows a hemodynamic finding, find it. This is a beautiful case report and a beautiful example of, gee whiz, we didn't find it, but then we did find it because we looked for it harder. So I think that's our hats off to the people who did the procedure and persisting with it, rather than just sort of saying, well, I don't see it, must not be there. The echo must be wrong or whatever. So I think once you see something like that, sort of prove to yourself that it's not there, rather than saying, I can't find it, try to find it. Again, as has been mentioned already, the LVOT echo gradients without evidence of AS. I mean, we have great echo, so we can see aortic valve stenosis. And so if you don't see that, that should certainly raise a suspicion, as in this case, that there was something else going on here. And a subaortic membrane being the thing that was found in this particular case report, but certainly dynamic obstruction. Usually you already have that information when you go to the cath lab, but in cases like this, with a subaortic membrane, sometimes you don't. I think that with this subaortic obstruction, like this membrane, as I mentioned a moment ago, minimal side holes, MPA2 or even a 1, straight catheter, you can put it over a wire, as Guru was talking about, or over a pressure wire as well, and then be very precise pullback. Might have helped in this case. It's hard to speculate because this is a very flexible membrane, which is unusual, as we've already pointed out. I think the standard pigtail catheters, and I've seen this, I remember back when I was a very young attending, I had one of my attendings who was just behind me who had a hypertroph and used a multi-side hole pigtail catheter and couldn't find a gradient. Well, that was before he had great echo. And the reason for that is it was being, quote, sort of contaminated by the fact that you had multiple side holes. So I think considering using a single end-hole catheter with either a pressure wire or guide wire. And then, as I mentioned a moment ago, pressure wire at the end of this is another way of doing it, so that you have what the LV pressure is, and then as you pull it back, you can also see where this gradient is as well into the aorta. So in any event, and that might have not splayed this apart as much because that pressure wire or even a guide wire would not have put as much pressure on the structure. But again, all speculations. But as I said a moment ago, my hat is off to the people who did the procedures and persisted at finding the problem for this. And it was fortunate for the individual to then be able to undergo surgery to address that.
Thank you. That's an excellent summary. I'm going to stop sharing, just talk to each other now. So I think these exercises really are helpful to those interested in this area and for diagnosis in ways that we would not otherwise consider. And we've talked about this at other forums and published on the 7 or 8 different ways to get an aortic LV gradient, an outflow tract gradient. And the single catheter pullback is the least the least desirable, and the multi-lumen high fidelity system is the most desirable. And yet here's our most desirable dual lumen pigtail failing on this. And that's what I found particularly interesting. And so then would I have gone back with my pressure wire on a multi-purpose catheter because I moved the gradient causing membrane away with the first system? So I'm still struggling with that, but obviously something did that, and you persisted to prove it to us, and now I stand in wonder, and I think it's very good. So Dr. Fang, thank you for a great case. I just and Guru, Dr. Hiremath, and Dr. Seto, Dr. Dean, I want to just say thank you very much.